Hi everyone, welcome for this nice luncheon. Today we're going to talk about vaccines. So I'm Richard Nathan, I do infectious disease here. I've been in Idaho Falls for 21 years, and basically I just do infectious disease. We do some clinical research, but we're not talking about any of that today. And I don't think I have any ties to any company that we're going to talk about, and whatever vaccines we mention are pretty standard. And yesterday we were blessed by the pediatric department with some suggestions about this lecture, and we're going to talk some cool stuff. Everything that we're talking about today is applicable or to you guys, to your families, or people that you know. So I wanted something to be kind of useful. And this is pro-vaccine, not anti-vaccine. So if anyone's an anti-vaxxer, that's cool, but this is not really, we're not really talking about that. Vaccines have saved lots of people over the years. Basically, the World Health Organization says 154 million lives were saved, and we've cut down on all sorts of diseases: diphtheria, measles, smallpox. Deaths are zero. Hepatitis A we've drastically reduced, and pneumococcal disease we've reduced, and we're doing better all the time. We're going to have just maybe 3 or 4 slides on influenza. Influenza really isn't so relevant right now because the season is just about over, but we have bird flu, and you guys are probably hearing about bird flu, and it's going to be in the media for the next few months easily. And probably it's a big deal because it's going to kill a lot of our chickens, turkeys, birds, songbirds, and whatnot. And some cows are being affected. So basically we're looking at influenza A, and there are a lot of different types of influenza A. They're marked by an H and an N, and there are 18 types of H and 11 types of N. And they're just basically like these proteins that kind of bind to cells in your respiratory tract. And they're important. And based on which one you have, which one there is, it might be really relevant to the infection. This year we had H1N1, H3N2, and 2B types in our vaccine component. And basically they worked. They worked pretty well. For pediatrics and adults, they're somewhere up to the 80% range. There's the MMWR has an interim publication that came out in February. It talks about this in detail, but basically the vaccine was a pretty good match, and it pretty much worked as good as we're going to get right now. Influenza B. Influenza A is always the important one. Influenza B does not infect animals. And because it doesn't infect animals, it mutates very slowly. It usually is a little bit more prevalent in children, and usually occurs a little bit later in the season. But this is where it's at. FDA finds evidence of bird flu virus in grocery store milk, but expresses confidence in safety of dairy supply. Are we confident or not?
No.
We are confident, because I have only maybe one more slide left of this. So it's not that important. And the reason it's not that important is this avian influenza that's going around is H5N1. Okay, so if we go back a couple of slides, remember I said we have a lot of types of H's and a lot of types of N's. H5 doesn't really work well with our respiratory tract. It really doesn't affect it really doesn't infect human cells. We have very few avian receptors in our body, and even then it's not really a good match for this avian influenza that's spreading around. There have been a handful of human cases, and they're always tracked with very close contact with birds. People, they're shut into these bird coops, these large farms where they have the birds, and there's poor ventilation. And even then, it's just a very short, self-limited disease. So for a virus to spread, you need like 3 properties. It has to spread easily among humans, which this bird flu does not. It has to cause human disease, which it really doesn't do. And it has to be novel. It has to be something like cool and new and out there. And it's really not. Basically, the H5N1 binds to a protein called hemoglobin 5. There's that old lock and key model, like we saw with the COVID and even the RSV. It gets into the respiratory tissue, and it kind of unlocks the cell to open up and let the virus genetic material to spread. But it doesn't do that for humans. Birds have an avian receptor. It looks like cows have a little bit of this receptor too. And we've had some cows that are getting sick, but very few die. And most of them get over it. And it just doesn't bind to our airway cells. Now, in terms of the milk, okay, it just came out in the last few days that it's been reported in the milk supply. Is that really a big deal? It's a respiratory virus, not a GI virus, the H5N1, the avian flu, and it's pasteurized. The milk that we drink is pasteurized. And what they're detecting is some genetic material from the H5N1 virus particles. They're not necessarily reporting viable virus. The virus might not, it probably doesn't do, when it goes through the pasteurization process, which goes to 71.5 degrees Celsius, or 161 degrees Fahrenheit, I believe, it basically denatures the virus. So there really shouldn't be any viable virus in the milk. We're just picking up whatever residual is left over after this pasteurization process. But we'll hear about this for months and months and months because everyone is going to freak out. And we'll have a lot of bird deaths, but I doubt this will affect humans, affect us in terms of infection. So before I move on, any questions on the bird flu? No, okay, so now we have liver disease. Okay, this is chicken liver, which is a favorite of mine. I also like calf liver. Hepatitis, which we're getting to, with this hepatitis B vaccine, is a disease, inflammation of the liver. And there's some viruses can target the liver. Hepatitis B is one of the big ones. Okay, this is very applicable to people here, by the way, this little talk. We have some non-responders. Has anyone known a non-responder? Yes, like most of the room? You're a non-responder. Look at that, how cool. Not cool for you. Have you gotten a second vaccine? Do they say, get it again?
I've gotten a lot.
You've gotten a lot. You probably got the Combavax? Did you get the Endorix?
I'm not sure.
Okay. What about the new one?
I don't think I've gotten
Oh my gosh, there's a new vaccine. It's been out for years. And that's the one that we give here in this hospital. And it's better. But we'll talk about that. That's really cool. So this is applicable. You know, everybody knows someone that's a non-responder. Okay, generally antibody levels less than 10. And in fact, I responded when I took mine. I took Endorix when it came out. There were 2 on the market, and there are 3 on the market now. Something called Recombavax, which was the first recombinant vaccine. Something called Endorix, which had been used in Europe, and it was $10 cheaper, and that's why I took it. And because I was self-paid. And then there's something called Heplicel that came out a few years ago. That's cool. So hepatitis B remains a significant clinical burden in the United States. Most people are not aware that they have it. There's some deaths, and it could really affect people that have the disease. There's new recommendations, and basically the recommendations are adults should get the vaccine. So adults aged 60 years with risk factors for hepatitis B should get a hepatitis B vaccine. That's kind of updated. And they say all adults between 19 and 59 should be vaccinated for hepatitis B. So the powers that be are very into the hepatitis B vaccine. Okay, there's a vaccine that came out a few years ago, easily a few years ago, called Heplicel B. And I jumped on this one. This is a cool one. And the reason it's cool is for a couple of reasons. First, the old one, the Endorix, or even the Recombavax, you have three-dose schedule. Dose 1, day 0, day 30, and then 6 months. With the updated vaccine, it's day 0, day 30. So you're done in a month with this vaccine. But what else is important about it? And this is the cool stuff. When you take the Engerix, okay, which is it's been the most common one, but it's really no real difference than Recombavax. You've got the response. The response after 3 doses is about 81% for this at 7 months. And the response for Engerix, again over here, is low. It's about 70% over time. You'd really want a more robust response for hepatitis B vaccine. For the HepliSav, the response at 3 months is 95%, and at 7 months is 98%, and over here is 90 and 95%. Much more robust response, much faster, more robust. It's really choice. And you have a lot more compliance because the dosage schedule is day 0, day 30. So this is what we've shifted to. I'm pretty sure Costco has this one too, and a lot of places have it. I think this is really becoming the more important vaccine. But then there's some subgroups. This blows me away. If you look at patients with diabetes, which is half the country, I think. Dr. Morgan, is it half the country?
Pretty close.
Pretty close. HepliSav, the response rate is 90%. With Engerix, it's 65%. Non-responders. And for other groups, male, HepliSav is 94%. Engerix is 78%. Not cool. Older, 94% versus 78%. Obese, 94% versus 75%. And smokers, I don't have any idea why, 95% versus 78%. So there are noticeable differences in a lot of different subgroups. So for a while, I've been recommending this one. I don't even actually know who used this. I'm not sure who produces this vaccine, but in any case, that's what we've moved to here at this hospital. And if you're a non-responder or know a non-responder, this might be something to think about strongly. Getting redosed with something like this. But I assume, I don't want to talk for the hospital, but I assume the hospital would just pay for it through employee health. Is that right? Does anyone know? Probably
Yeah.
do. Yes. Good. Excellent. So we want to keep them busy if we can. If you are a non-responder or you know a non-responder, you might want to look into that just so you have some protection. And yeah, I think that's about it. But basically, persons with anti-hepatitis B less than 10, less than or equal to 10 is what we recommend. Now the next thing is human papillomavirus. Oh, does anyone have any questions about that? Or human papillomavirus. This comes up all the time. We have a vaccine for it, and there's actually really only one on the market. It's the most common sexually transmitted disease in the United States. It's a small DNA virus. There are a ton of types, over 200 types. And we've had our first vaccine license in 2006. Okay, so there are around 40 types that have a mucosal site of infection. You have the oncogenic strains, the HPV 16 and 18, that can cause cervical cancer, anogenital cancers, oropharyngeal cancers, low-grade cervical disease. You've got some low-risk ones, HPV type 6 and 11, that can cause genital warts, laryngeal papillomas, and low-grade cervical disease, and then some cutaneous ones, like warts in your hands and feet. Most people clear their HPV B virus infection on their own. About 90% are just cleared through regular immunity. But you can get persistent infection and cervical cancer decades later, and also esophageal cancer. I don't have a slide for that, but that's always a bad one, and they never end well. The most common manifestations are genital warts and some of these other things, cancer, nasty stuff. So if we take a look at this little slide over here, number of HPV-associated and HPV attributable cancer cases per year. So cervical cancer, about 91% was caused by a type of HPV. Obviously, mostly in females, not so much in males. Vaginal cancers, 75% are thought to be HPV related. Vulvar cancer, penis cancer. The ratio flipped over there. Anal cancer, oropharyngeal cancer. HPV is really common for all of that. Basically, it's direct contact. It's very easy to pass from one person to another. And this is always an interesting slide. Cumulative incidence of any HPV infection months after sexual initiation. So roughly at 4 years, around 50% or more of people have HPV. There are 13 million people with a new annual infection, and it's common among adolescents and young adults. And we spend a ton of money managing all of this. But we have a vaccine, and there's actually only one vaccine. There are 3 vaccines licensed in the United States, but only Gardasil is available. I'm not exactly sure why. Well, it's probably because it covers more types, and it's the one that most people would use. It's not a live vaccine, and it's given intramuscularly, and basically everybody should get this. It covers types 6, 11, 16, 18. It covers a lot of the bad types. And I assume that over time, they'll have a few more types of HPV in the vaccine. It always seems to be the way things go that way. The FDA indications are females 9 to age 45 and males aged 9 to 45. So our kids should be getting this. My kids have gotten it. And adults might want to think about it up to age 45. It's very efficacious, and even if you've had a prior, even if anyone has had a prior infection, this will prevent some of the other strains. It's been available forever, but basically since 2018, we expanded the age to 45. So that's always something good to think about. If you've got any friends, patients, whatever, it might be always good to suggest that if they look like they're in a high-risk group. FDA approved. Oh, and they have something called shared decision-making, which I always hate, but shared decision-making, where you chat with a patient and say, hey, this might be a good idea, what do you think? And they'll say, gee, I don't know, what do you think? So that's pretty much shared decision making. But for people that are in high-risk groups, this is a good one. We think it's long-lasting. We think it protects at least 12 years, but we don't know how long it actually lasts. And they're looking at it. You can start at age 9. So kids 9 years old can get this and really should get this. Probably want to do it before they become sexually active, so 9 is a great time to do it. When you vaccinate them from 9 to 14, it's only 2 doses, and over 14 is a 3-dose regimen. Why that is, I don't really understand why, but that's how it's been. And accelerated schedule using minimal intervals is not recommended. So no alternative dosing schedules for this one. For people that are immunocompromised, 3 doses. So if they're on some fancy medication that immunosuppresses them, if they have some kind of funky disease, you should err on the side of giving 3 doses. And we've got the shared decision making, and persons in a long-term, usually monogamous sexual partnership are not likely to acquire a new HPV infection. So there's that. And most sexually active adults have been exposed to some HPV types. although not necessarily all of the HPV types targeted by the vaccination. It doesn't protect against all 200 types of HPV, but it gets most of the oncologic strains. We don't really have a good antibody test for HPV, and it might be low, effectiveness might be low, and high risk for HPV infection of disease. Adults with multiple lifetime sexual partners and likely previous infection with HPV, but do your best to vaccinate these people. There's no therapeutic effect of the HPV on infection, so if someone has HPV, getting the vaccine doesn't cure them, which was sad. I was hoping that when these drugs were in development, it would actually work for a cure, but it does not. And they recommend delaying until after pregnancy. And my understanding is that it wasn't studied in pregnancy. And if you're pregnant when you get the vaccine, they suggest, reporting it. And in terms of safety, okay, for anyone that has gotten this, it's been given 135 million doses, but syncope is a biggie. So people really feel this vaccine when they get it, and it's males and females. So be careful about that. And they should be seated or lying down during vaccination and remain in that position for 15 minutes. That's kind of the biggie. In terms of the vaccine coverage among adolescents in the United States, females and males have gotten about 78% or so vaccinated, but up to date, meaning like they've had the full course of the vaccine, is much lower. So it's hard when you're spacing out vaccines, it's hard to get that second or third dose in, but we want to do that. But it's basically, there's some discussion, some parents might not be so enthusiastic about it. These vaccines have been out for years now, and they're safe, and they've been given to hundreds of millions of people around the world. And we recommend discussing it when you're talking about vaccines with parents. Does anyone have any questions about the HPV before we move on? Nothing? No one? I will say something very interesting, is that when the HPV first came out, like a long time ago, I think it was around 2008, I was giving the HPV vaccine to the children of doctors in Idaho Falls. The pediatricians I think they were afraid to give the vaccine. They weren't really sure, like, if the community would accept the vaccine, and they were very, very hesitant to stock it. And the gynecologists, oddly enough, were super in favor. They were like really in favor of the vaccine. So there was a little bit of a split there, which I've really never seen. But I'm out of the Gardasil business because they're common now. Everybody gives it, so there's kind of a happy ending. Okay, so this is the big one. Our pediatrics colleagues wanted me to talk about this. And I'm like, why should we talk about this? But we will. Choosing an alternative vaccine schedule. And I understand that we have an alternate vaccine schedule here.
Oh, yeah.
We have an alternate vaccine. Has anyone heard much about alternative vaccine schedules?
No.
No? Oh, good. Don't. Okay. Okay, no. None of that. It's bad. Okay? Just don't go there. But there are movements among people, anti-vaxxers, that say, oh my God, we're giving so many vaccines. We shouldn't be doing this. And all of that. And there's a guy named Robert W. Sears. I was specifically asked to talk about this guy, who is a crackpot. My understanding. At least my understanding. Maybe not true, but his Wikipedia page is not flattering. I'll say that. He wrote something called the Vaccine Book, Making the Right Decision for Your Child. And we have another one, Dr. Bob. Dr. Bob has an alternate vaccine schedule of how he thinks we should give vaccines. And the argument is too many vaccines too early. Is that right?
Yep.
Too many vaccines, we're giving kids too many vaccines. And I remember this, I was alive for this one. Jenny McCarthy was on Larry King. People know who Larry King is anymore? Yeah? Okay, so I'm not that old. And she's talking about how terrible it is, and the vaccines caused autism in her kid, which it did not. So anyway, times have changed. In 1900, we gave one vaccine called smallpox. We, and as the collective we, not really me, because I was not here. And they gave a shot, a one-time shot of smallpox. It was protective, and kids lived. And in 1980, actually, there weren't that many vaccines. DTP, polio, which was oral by then, and MMR. That's it. And in 2015, we got a whole bunch more vaccines. They just keep popping out. However, it turns out that there are fewer immunologic components in vaccines today than 100 years ago. Vaccines are purer. Medicine is purer. Everything is purer. We have like beakers and stuff like that where they filter out impurities, which is really amazing. So in terms of the year 1900, we had the smallpox vaccine, and the number of antigens was 200. Actually, now we have the monkeypox vaccine, which is going commercial this month, and it's in a state where it's not available right now. But that actually works for smallpox, if we were ever worried about smallpox. It's going to be commercially available at the local pharmacy, I suppose. So there's 200 antigens in the year 1900. And then in 1980, when all of these vaccines came out, there were a lot of antigens. This pertussis in particular, it was kind of the dirtiest vaccine. But then the year 2015 hit, and the number of antigens dropped by quite a bit, down to 150 to 159 based on the schedules. You're just purer. So going down from, again, back from 200 to now, we're exposed to less impurities from the vaccines themselves. But from birth, infants are challenged by bacteria in their environment. We're exposed to things all day, every day. And their vigorous responses within the first week of life keeps colonizing bacteria from invading. And if we did not have an immune system capable of taking care of these challenges, we die. But are infants too young to be vaccinated? So we started giving hepatitis B at birth. And in some countries, they give something called BCG at birth. And they work. It turns out that they work. Some people are not non-responders. They actually respond. And actually, most infants do respond to the hepatitis B vaccine at birth. 95% of infants will develop protective immunity to all of these vaccines by 6 months of age. And we need to be fully immunized to get certain infections by 6 months of age because maternal immunity wears off. And we don't really want our infants to develop meningitis, pertussis, bad respiratory infections like pertussis or severe pneumonia. So the anti-vaxxers, they talk about this aluminum overload. We have this terrible aluminum problem. I actually saw that guy, RFK Jr., talk about this on the TV. About aluminum overload. Right before he was on C-SPAN, and I didn't realize he was a crackpot at the time. This was a while ago, and he was more of an environmental lawyer, and he was talking about this. So we go back to rubber seals. Alternative schedules suggest only one aluminum-containing vaccine at a time in infant years. By spreading out the shots, you spread out the exposure so infants can process the aluminum without it reaching toxic levels. That's nonsense, actually. Aluminum is the third most abundant element in the earth. We breathe it, we eat it, it's in our food, in our baking components, in that baking powder, baking stuff. It's all there. Adults typically ingest 5 to 10 milligrams of aluminum a day. And aluminum is found naturally in teas, herbs, and spices. Leavening agents, that's what it is. Anti-caking agents, emulsifiers, coloring agents, it's all around. It's pancake mix, self-rising flours, baking powder, that's what I was looking for. processed cheese and cornbread. It's everywhere. It's found in breast milk and infant formula. By 6 months of age, if they're on schedule, infants will have 4 milligrams from vaccines, breast milk 10 milligrams, infant formula 30, or if they're on soy, they get a little bit more. But is it really bad? 100% of aluminum is absorbed following vaccination, and only 1% of aluminum is absorbed by eating, by ingestion. It binds to something called transferrin, and it's eliminated in the kidneys. Well, it turns out that we actually can get rid of aluminum. 50% is eliminated in the first 24 hours, 85% eliminated in 13 days, and 96% in 3 years. We get rid of most of it. Okay, we don't get rid of all of the aluminum in our body, but we get rid of most of it. By the end of the first year of life, an infant will get will have 0.1 milligram from breast milk, 0.1 milligram from infant formula, and 0.1 milligram from vaccines. It's a negligible amount. And they have a total of 50 to 100 milligrams from other sources, basically food. Aluminum can cause all sorts of terrible things, encephalopathy, and there are problems for people on dialysis. But as long as you have kidneys, you're in good shape. Circulating levels of aluminum in those with symptoms are super high, between 100 and 1,000 nanograms per ml. And typically children and adults have 1 to 5 nanograms per ml in their blood. So injected vaccines don't raise the level. So it really doesn't work. You know, they've made a big argument about aluminum, but it's really a negligible amount. And there are lots of aluminum references. And there's a lot of scientific data on this because it's been topical for a while, but it's really not a biggie. Is that what you were looking for? Yes. Okay, good. Anything else about alternative vaccine schedules that I may or may not know? But no, just suck it up and go with what the government recommends. Okay, this is Dr. Bob's alternative vaccine schedule. Okay, are more shots stressful? Studies showing that 2 shots are not more likely to reduce cortisol than 1. The problem with an alternative schedule is it's not science-based. You might get more needle phobia because you keep bringing these kids in to get vaccinated. You increase the time in which children are susceptible to vaccine-preventable diseases. The waiting room fills up, and there's no benefit to the infant. So yes, I'm not so in favor of the alternative schedule. It doesn't really make scientific sense. It doesn't really work. Vaccines are safe for the most part. Now we have another one, an egg allergy, right? Okay. So this is another request from our pediatric colleagues. Anyone have an egg allergy? Or have kids with an egg allergy? You have a kid with an egg allergy. You have 2 kids. Do you vaccinate them with egg-laden influenza vaccine?
No, they both outgrown it. But when they had the egg allergy, they used the nasal mist instead of the injection. So we still got our flu vaccines, we just did it with
That is too cool. That's good to hear. But we're going to talk about that in just a second. There's nothing wrong with that. There was nothing wrong with that. That is totally 100% cool. Okay, about 1 to 3% of children can have an egg allergy. It resolves for most during childhood and adolescence. Basically, the diagnosis is a clear history of immediate allergic reaction to egg or egg-containing foods. And that's basically where we are. We're gonna hold off on that in just a second because you'll see why. It turns out that we have some egg-free vaccines. So we have the nasal ones. Now we have a couple of injectables that are totally egg-free. There's the flu Cellvax and the flu block, and those are generally easy to get. They have them. I know Costco has them. Sam's Club has them. I'm sure Walgreens has them, and some of the other pharmacies have them. And if there's any concern, you can go egg-free any day you want. In terms of all of the other vaccines that we have, there's just a small amount of egg protein in the vaccines, real tiny. But we have ACIP recommendations. Okay, the recommendations, they were updated fairly recently in 2022, and says basically, if you have an egg allergy, take the egg vaccine. It's cool. It's now totally cool. If a vaccine other than the non-egg, these two over here, the flu cell vax and the flu block, is used, the selected vaccine should be administered in an inpatient or outpatient medical setting, including but not necessarily limited to wherever hospitals, clinics, health departments, physician offices. Vaccine administration should be supervised by a healthcare provider who's able to recognize and manage severe allergic reactions. And we're going to talk about this one too. This is cool. Basically, the American Academy of Pediatrics says no additional measures recommended for persons with egg allergy. Anyone can get it. Children with egg allergies can receive any influenza vaccine without any additional precautions beyond those recommended for all vaccines. Not necessary to inquire about or screen for egg allergy prior to influenza vaccination. That's how far we've gone with this one. So, but there's nothing wrong with the nasal ones. It's cool, and there's no reason not to use one of the alternative influenza vaccines. They all work pretty well. But here we go. Although allergic reactions are a common concern for vaccine providers, these reactions are uncommon and anaphylaxis is rare, occurring at a rate of approximately 1 per million doses for many vaccines. Epinephrine and equipment for managing an airway should be available for immediate use. That was the ACIP, that was the US government recommendation at the moment. We should be prepared for an anaphylactic reaction for every 1 in 1 million episodes. Now this is what we used to do, and what we used to do wasn't that long ago. Maybe a vaccine skin test, a graded administration of vaccine. You give small amounts, diluted, stronger with observation over a period of like a year, it seems, or a split dose of the vaccine. Okay, we don't do any of that stuff anymore. Now this is the big policy question is, do we even need to make any kind of recommendation for someone with an egg allergy? Can we just like vaccinate them even without medical supervision at a Home Depot? And the answer is probably yes. You probably could. You probably don't need any special supervision. But we haven't gotten there yet, but that's the direction that things are going. Egg allergy is more common in younger children and often coexists with asthma. But younger children and people with asthma are at an increased risk of severe influenza illness. So the people that need it the most really should be getting the vaccine. But again, we have alternatives if you guys didn't want to use the egg-based products. And they're incredibly readily available. Okay, so they looked at this, and these slides are super interesting. What happens within 4 hours? They've watched people 4 hours after vaccination. They looked for things like death, anaphylaxis, or allergic symptoms requiring hospitalization. Those are the critical ones, and the important reactions are allergic reaction symptoms of various kinds. It doesn't really matter too much, as you'll see. They did a whole bunch of studies, and this is like the super interesting chart. Summary of events by vaccine type. Egg allergy of all severities. So death, outcome of death from one of these vaccines. None, 0, none. Anaphylaxis, none. Reaction requiring hospitalization, none. Reaction requiring outpatient or ED attention, a few. Very low, but a few. These are the non-egg containing products. And allergic reaction, including cardiovascular symptoms, respiratory symptoms, angioedema, or generalized urticaria, a few, not much. Now, egg allergies of all severities. This is persons with anaphylaxis to eggs. So these are people that are the bad ones. Really nothing's going on here. So if you look at the egg people, no death, no anaphylaxis, no reaction requiring hospitalization, no reaction requiring ED attention, nothing, nothing. So it actually appears to be safer than expected, and that is humbling sometimes because you never know what you're going to find until you do a study. This basically says there's very low chances of any kind of reaction to the anaphylaxis or allergies to the eggs. Issues related to trust from the patient's perspective. A change in recommendations might mean vaccination occurs more widely. More people might get the vaccine if we change the rules even further. And the fact that egg-based vaccines are less expensive might reinforce the belief that providers or healthcare systems do not care about the necessary resources to provide a potentially safer vaccine. Probably the egg-based vaccines are about $10 cheaper. It's like usually like $20 to $30. The difference between an egg-based vaccine versus an acellular vaccine, something along those lines. I'm sure the pricing changes every season. They might change, if we have the bad bird flu, they might change, the egg-based ones might change actually and become more expensive. And, did we finish? Oh, I think I finished actually. Oh my gosh. I finished early. Cool, how's that? Okay. Are there any questions about these or any other vaccines? Yes.
So what do you think about the antibiotics reactions with it?
The which one?
They, the particles of antibiotics and stuff that they add in some of the vaccines. What's your take on that reaction?
It's okay. Yeah, so basically, so it depends on the vaccine, but basically, generally, it's just minimal concentrations. Basically, if, depending on the vaccine, they just really use it to suppress any kind of bacterial growth in the bottle. It really doesn't get any kind of appreciable levels in a human.
Okay, I was just curious because my son had a reaction and they attributed it to the antibiotic in the vaccine.
Which vaccine was it?
I can't remember. It was so many years ago. He's an adult now. But sometimes we get asked about, do you have a reaction, not just to egg, but like to, and sometimes we don't. So it just kind of, it's very hit and miss as he got older. So
Yeah.
we've just kind of always taken the approach of asking ourselves just to keep it from happening because he got the full hives within like
sure.
just a few minutes afterwards.
Mm.
But I just didn't know if he heard that was still a thing or, I mean,
Yeah.
it's been so long since I looked
So
at
it's
it.
definitely good to know which one it was. But often there's either he's done with the vaccine entirely,
Right.
or you can switch to a different brand, a different process.
I just didn't even know if they still even used it in the vaccines anymore.
I'm sorry?
I just still didn't even know if they still used that in the vaccine components anymore.
Not for the most part. There's a sterility is better.
He's older now, so,
Uh-huh.
I didn't know if that was a thing back then or.
Probably a thing back then. But no, there was never any appreciable. They used to use like thimerosal in
Yeah.
vaccines, and they've really come away from that. Even then, the levels were negligible. Then I heard JFK Jr. talk about that on C-SPAN, and anyway, yeah, he pivoted from environmental law to anti-vaccine, and he was good at that. He's been good at it. Any pediatric questions? No.
What do you consider a reason not to get vaccinated? Like
None.
who falls in that category?
No one. Everybody should
No,
get
no
vaccinated.
one falls in the category of not getting vaccinated.
Everybody should get vaccinated. Yeah.
Well, then what's the reaction?
What's
Like,
that?
If they have a reaction, they just look at
Yeah.
try again.
Pretty much. So it depends. It's kind of global. So are we talking like a pediatric patient that has a reaction? It just doesn't really happen that often.
I know it totally doesn't. People will have a reaction as a child and then never get
Yeah.
vaccinated again.
Yeah.
So I just wanted clarification.
Yeah, they should go back and.
They should go back and try again.
Yeah. So they don't die from a terrible illness. Yes.
Because I'm pretty sure all the adults have heard it in their room. Like I had a reaction as a child. And we're not gonna do it again.
So
Yeah.
people do that. They shouldn't. because some of these diseases are bad. Yeah, we may have had a case of mumps in this area just in the last week, which I've never seen. Has anyone seen measles in this room? Anyone in this room seen measles or mumps?
I had mumps when I was a child.
Did you ever see it? Anyone with it? What about chickenpox? Ever see anyone with chickenpox? You've seen it?
I had chickenpox.
Well, you had chickenpox, but did your children have chickenpox?
Yes.
You did?
Yes.
Okay, well, there's that.
They're all neighbors.
My daughter got it when she was 2.
Yeah.
And
So if you were born before, say, the 1970s,
Yes,
because I had the measles and the chickenpox and, you know, the mumps,
yeah.
should I be asking my doctor if I've had certain vaccinations that
You
might
could.
not have?
Or it might be, if you're an Idaho resident, it might be on your, it might be in the database. They might be able to look it up. And even the pharmacy might be able to look it up. So and you can get levels, especially for things that are really pertinent. Measles is the most pertinent, it's the most important thing. It's the one probably virus that you really don't want, because it really destroys all of your memory, most of the memory in your immune system. So you're basically starting from scratch for someone that gets the measles when they're older. Very, very bad. So that's like the number one thing that you'd want to find out about. For something like shingles, that's generally given, the vaccine series is given at age 50. And that's a good one to get.
What about pneumonia? What's the recommendations for?
So there are a few different types of pneumonia vaccines. There's the Pneumovax, which is kind of fading into oblivion right now, I think. That is, it's really on the way out. And there are 2 other pneumonia vaccines to my knowledge. One from Merck, that's a 15-valent vaccine, and I don't recall the name of it. And then there's the Prevnar 20, which is more popular. It's not necessarily better, but it's definitely more popular. You can make some arguments that the 15 might be good, especially in certain situations, but the 20 is more popular, and that's kind of the thing at the moment.
So what's the age range?
And basically age 50 and above. For my patients I have that I know are going to be immune suppressed, I try to accelerate try to do it early, but the patients may have to pay out of pocket. So things like shingles vaccine, pneumonia vaccine, it's nice to do off immunosuppressives if possible.
If you have shingles, do you need the vaccine?
Yes, oh my gosh, yes. So for shingles, so there were 2 shingles vaccines that have been on the US market. One is called Zostavax, which is no longer on the market. And the other is called Shingrix, which is on the market. And it's just it's more effective than the older one. And that's why the older one faded. So if for someone that got the original vaccine, the Zostavax, they should get the Shingrix. And if you've had shingles, you should get the Shingrix. So the shingles vaccine is good for primary and secondary prevention. So primary prevention it'll prevent you from getting the disease in the first place. And secondary prevention prevents you from getting it once you've had the disease. So someone that's had shingles, they get the vaccine, and they're less likely to get shingles infection again. Or if they get shingles again, or if they get shingles the first time when they're vaccinated, it should be a more mild case. Shingles is unpredictable. You might get a very mild case where you have a little rash somewhere and you don't even realize you have a rash. And someone will say, "What's that rash over there?" To where you can get an encephalitis. Who was that senator from California? There was a senator from California that got encephalitis recently, and she died. Does anyone know the name? Anyone? Yeah, there was a senator, and I wish they had announced whether she had gotten the vaccine or not. I suspect not, because I've never seen like a really bad shingles infection in someone that's been vaccinated. I'd be real curious. Dianne Feinstein, that is her name. And she was totally disabled from shingles. And Yeah, she could have used the vaccine, and she would have had insurance, and she had plenty of money. So I'd love to know whether she had it or not. I wish they had announced it. I looked around to see whether she had the vaccine or not, but I couldn't find it.
If you, the Shingrix,
Uh-huh.
is that all you ever need for the rest of your life, or
That's what they.
booster type thing?
That's what we know right now. That's the current recommendation is 2, and it hasn't been on the market for that long, like, I don't know, 5 or so years probably. So I don't think it's known. I don't think it's known. It's known. Like, but just will it boost? It probably will boost just fine.
Google says
For some technical reasons, the pneumonia vaccine, like the Prevnar 20 or the one from Merck, which I don't recall, they'll boost. They're good. They're robust, and if you need, you can get another one later on. Okay. One other thing I should mention is pertussis. Are you guys up to date on your pertussis? So pertussis is a respiratory infection that is really nasty. It's very easy to treat. The treatment is really a Z-pack. It spreads quickly within a family. Something like 90% of family members will get it if one person has it. And again, treatment is very easy. It's a Z-pack. It's probably about $4 or $5 treatment total in terms of cost. But people will cough for 2 straight months, and a terrible cough where they'll break ribs. And with the pertussis, there's no cure for that cough. That cough just keeps going on and on and on. The vaccine itself, which we have as adults, we'll get the Tdap booster, big T, small d, small a, small p, is, and that's the one that you would get at, wherever, at the doctor's office or at the pharmacy. The pharmacist will know that. The probably wears off, the pertussis part, where it probably wears off by 4 or 5 years. The recommendation is every 10 years, but I get mine every like 4 years. And we've known this for a while. We've known that the pertussis component really wears off. We've known this for a long time.
But it's not available as just pertussis.
No,
You just get a
no,
Tdap.
it's a Tdap, yeah, right. So the recommendation is every 10 years, but I do it more frequently than that. Personally, just because I don't want pertussis.
So what about is there anything on like non-responsive, if you're non-responsive to MMRs or something, like have they done any, you talked about the FB one, but is there anything?
Yeah, it's probably just a redose. And we can measure, so it's very easy for us to measure, especially the measles level for immunity. And it's kind of a big deal because we see little pockets of measles. So I've actually seen measles once. When I was in medical school in 1992, there was a case of the measles at this hospital, maybe 91, case of the measles at a hospital I was working at. And I thought, that's cool, I should go and see this case of the measles, and I did. And I thought, measles is a dime a dozen. Still in my era, there was still, measles hadn't been expunged. But that was it, that was the last time I saw measles from that point on. And if you ask the pediatricians, not the oldest ones, but if you ask like almost every pediatrician, they'll probably, here in town, they'll probably tell you they've never seen a case of the measles. You have to have luck. You have to be in a little pocket where they have the measles. So,
How many times though, did they,
what?
how many times do they keep trying?
How many times what?
Like how many times do they keep trying to get you?
It's not really established. I will say that you can measure the titer, and if you don't have an adequate titer, you get the vaccination over again, and it's easy enough to do.
I've had 7, so I'm just curious.
And what?
I've had 7.
So, and you didn't respond?
So I gave up, but I didn't know like
that's
if
too bad.
anything new had come out, that, to try something again.
So for that, nothing new came out. There's no new MMR vaccine, to my knowledge. I don't think there's anything, there's no special thing. You want to avoid measles, though, whatever you do.
That's my theory. But I was thinking,
And if we were to have an outbreak here, which is possible, that we had there was a little mini outbreak in Boise, Meridian area, about maybe 6 months ago. We probably measure titers, or if we can't get titers quickly enough, we probably just give another vaccine so we can get those results to people that are like exposed.
What constitutes a mini outbreak?
One case,
Oh,
a single case is an epidemic. So the question is like, what is an epidemic? And an epidemic of something like, oh, I don't know, influenza. Nah, it could be a lot of cases, really a lot of cases. Epidemic of COVID. I'm not sure actually. I don't know the gross number. But for measles, which should be basically eradicated, or polio, which should be eradicated, a single case is an epidemic. You want to go the other way if you see that. So if you're in a room, I think the number is, if you're in a room with someone that has the measles, if you walk into a room, I think it's 3 hours later, there's still a fairly large chance of contracting the measles. It's extremely infectious. Yeah, that might be the single most important vaccine when you get down to it.
Do they still use the gun to administer the smallpox vaccine?
Oh, so we don't give a smallpox vaccine.
Oh, I thought you said that they have brought it back out.
No. So they have the monkeypox vaccine now.
Oh, okay.
So the smallpox vaccine, I had a smallpox vaccine because I'm in that age group that still got them, and I have a little mark on my shoulder for that. But no, they stopped giving the smallpox vaccine sometime in the 70s when they felt it was eradicated worldwide. But if you wanted to get a smallpox, if you wanted to be immune to smallpox, you would get the monkeypox vaccine when it's available, because it'll give cross protection. Okay, now monkeypox is another one. Just as a little aside, we have the good version of monkeypox. There are two types of monkeypox. There's clade 1 and clade 2. And in the clade 2, which is what we had, that's kind of the mild one, where people got a little sick, and it wasn't so bad. Clade 1, which is now reported in some African countries, has a 10% mortality rate. But the current monkeypox vaccine will cover that, and we don't have it in the United States. They're trying to keep that contained.
Thank you.